here we are. We're going to do exam 3 review. Now, we know exam 3 has a lot of information in it. And, I made this trying not to overburden you with a lot of extraneous information. I try to give you those concepts, which are really important. And the other thing I do with it, I give you pictures. There are a lot of pictures here to try to help you figure it out, okay? So, diabetes, what do you see? Well, does it matter if it's the adults or does it matter if it's children? It's polyphagia, polyuria, polydipsia. You're hungry, you're urinating, and you're drinking a lot. And you usually see weight loss in that. So, for instance, if you had an adolescent who had a BMI really high, so you know that they're eating a lot of different, things that they shouldn't or too much. And then they start urinating a lot. It's like, what might you anticipate for that child? Well, maybe it's going to be urinalysis, of course, but I'm sure a hemoglobin A1C, because we know that measures the last couple months of sugar in your body. And you should be less than 6. For adults. In children, you could go up to almost 8, okay, depending on your pediatrician. So your hemoglobin A1C is higher. So here's pictures just telling you the same. What do you see? You're urinating, you're hungry, and you're thirsty. Same thing. Now, remember, there's a difference between just diabetes, which is hyperglycemia, and diabetic ketoacidosis, okay? Diabetes just means your blood sugar is elevated. And elevated on a child would be above like 120. The number is not important, but it's elevated, okay, continuously. When you get to the point of diabetic ketoacidosis, yeah, your sugar is elevated, but you have ketones in your urine. And that's the difference in it. So those ketones start with acidosis, and then we start with all the issues related to DKA. How do we treat DKA? Well, we're going to give fluids and regular insulin, aren't we? So again, there it is in the bottom. You need hydration, insulin, and then electrolytes as we get those levels back. So hyperglycemia, DKA, there are differences in it. Now, hypoglycemia is when all of a sudden the blood sugars go low. I mean, I've seen people tolerate blood sugars of 40 and be awake and alert. And I've seen children with blood sugars of 80 get nauseous, vomiting, jittering. Those are the signs and symptoms of hypoglycemia. So maybe they can't tell you, maybe there's, getting a little bit unconscious or not as alert. But if you know they have diabetes, those are the signs and symptoms you would see. And how do we treat it? Well, if they're awake and alert, patient condition, we're going to give something by mouth. Orange juice is a great thing. Or sometimes they have those little fix-it little packages they can squirt or whatnot. It's fine. A lifesaver, something with sugar in it, get it back up. Even a glass of milk, I've seen one book say about it. Again, hypoglycemia, things you see. These are pictures for you to look at. Okay, pituitary function. When you think of pituitary, you think of growth and you think of urine. Those are the two different things, okay? So when we talk about the anterior posterior lobes, we talk about what each of them does. So when we are talking about the growth hormone in the anterior lobe of the pituitary, we're talking about how a child grows. Now, there is hypo and hyperpituitarism. Well, it's as simple as too big, too small. So that's as simple as what we get with pituitary dysfunction and growth. Now, when you're a little tiny little child, some parents say, I want to give my kid a chance to be above 4'6" because some children can be small. They're going to give them these growth hormone injections, usually daily, sometimes less than, but let's just say it's daily, but they're subcutaneous injections. So these parents and children have to be serious about getting their medicine because they are a subcutaneous injection. So hypo Pituitaryism, we can tell these things easily just by every time we go to the doctor, what do they do for children? They weigh them and they see how tall they are, and it's documented. And if they're constantly growing, we know their growth hormone's working. Now, if we see it's growing too quick, then we know it's hyperpituitaryism, okay?
Mm-hmm.
All right, posterior lobe of the pituitary gland has to do with fluid, some sort of fluid, and it's either diabetes insipidus or syndrome of inappropriate anti-diuretic hormone. I mean, when you see that and you're like, oh my God, how am I gonna, what does that mean? Well, diabetes insipidus is only 2 P's, okay? It has nothing to do with hunger, has only to do with urine and fluid. So too much to drink, too many urinating. So what do we need to look out for this is we need to look for dehydration, right? We need to get electrolytes are going to be a big deal. We're urinating all of this stuff out. Daily weights, intake output on both of these are key. That's how we measure this stuff. Now, the syndrome of inappropriate anti-diuretic hormone. Let's tear that word apart. Anti-diuretic, against urinating hormone. Inappropriate means too much, I'm not going to let you urinate hormone. So what do you have? You have urinary retention. Now, think about what happens with a body that gets too much fluid and you're not urinating. Well, you get puffy, you're going to gain weight. That's why daily weights, intake, and output are very important. And with these fluid retention, it could be even go to congestive failure, difficulty breathing, hypertension, could do all of those things. So what do we do for syndrome of anti-diuretic hormone? Well, we're going to try to look at that, and we're going to monitor fluid intake by limiting fluids. We are going to decrease the amount of salt in the diet because we don't want anything else to make you hold on to water a little bit more. And with diabetes insipidus, we are going to be given that vasopressin drug, okay? And we can use that also in hemophilia, if you remember that during that lecture. So again, here's a pretty picture. You can look at diabetes insipidus and SIDH, and you can look at one's big holding fluid and one's dry. So dry, diabetes insipidus, wet, SIADH. Okay, again, diabetes insipidus, too much to drink, too much urinating. And then the funny thing I think about it is infants. You know, they do get it as infants. And the way that we diagnose this is they're crying, 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 hungry, hungry, hungry. You give them milk, 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 and they're still crying, they're hungry. But give them a bottle of water and they settle down, which I think is bizarre, but I've actually seen it, okay? So diabetes insipidus, doesn't matter what you do with fluid intake, it just has to do with the hormones. We need to give those vasopressin. So again, one of the things, and I had to teach many nurses in my career, diabetes insipidus has not a darn thing to do with sugar. I don't even know why they call it diabetes insipidus, but it has nothing to do with the blood sugar. I've had many a nurse bring a patient back to my room and say, oh, the child has diabetes insipidus, his blood sugar is 102. And I go, so why did we do a blood sugar? No, because of diabetes. And I'm like, it's nothing to do with diabetes, but it's a common thing that happens. So we try to teach them that they didn't have to do that. So intake, output, daily weights, again, with either or, give the vasopressin. And again, this is a lifetime of this. This isn't just a once and done. There is no cure. It's just something you have to treat and look out for. Again, SIADH is big and full of fluids, right? So what do we do? Again, daily weights, intake, output, but water restriction, low sodium diet. And they might be given vasopressin, but these children with all the fluid they hold on, seizures is one of those precautions. Again, pretty pictures for you. Thyroid dysfunction, well, too much, too little. We know thyroid has a lot to do with growth and development in children, and without that in infants, we are going to see cognitive delays. So we do monitor it pretty closely. Now, one of the conditions, Graves, it's usually your adolescents, they have hyperthyroidism, and it's just too much thyroid hormone in the body. So they treat it with this polypryphosphate, or it's called PTU, is the initials that I've been commonly used with it. But one of the teachings, and I'm telling you, physicians don't teach anybody about this. That's why nursing, teaching is so important because we have time with our patients. One of the complications is leukopenia. Leukopenia is a decrease in white blood cells. No white blood cells, you're going to be apt for fevers, and you're also going to be apt for like sore throats. So side effect of this polypropyl or PTU is, fever and sore throats. How do we treat it? Well, we're going to treat it with glucocorticoids. Again, remember, what do steroids do? It also suppresses you, so you have to be careful. How do we treat hyperthyroidism? Well, we can go in there and ablate the thyroid, get rid of it, radioactive iodine. But again, they'll be on replacements for life after that. And thyroid storms is when all of a sudden this burst of thyroid hormone goes into the body, and everything goes up, 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 heart rate up, temperature up, blood pressure up, chest tightness, it feels horrible. And we treat that by trying to block that tachycardia with what? Beta blockers, because it blocks the beats, right? And then usually if they're having them, they'll go and do the thyroid and take it out. Hypothyroidism, sometimes we don't see it at birth, and it's something that later on we start to check. We start to see that cognitive delay. We start seeing decelerated growth. It means they're not growing the way they should. So why aren't they growing? That height and weight is so important on so many levels on taking care of children. But what do we see in hypothyroidism? The signs and symptoms are what tells us first. All the things you see in adults, dry skin, constipation, cold intolerance, all that you see. But the big thing with children is that decelerated growth. They're not growing as well. You're going to see that puffiness around the eyes, that sparse hair. You want your children with a lot of hair. I mean, older people, they're sort of normal not to have that full set of hair, but small children have that sparse hair. And then of course the constipation, they're going to be sleepy, but sparse hair, dry skin, and they're not growing the way they should. Again, another pretty picture for you. If you like to look at them both, put them together. I like them there so you can, make sense of it. Okay, let's go into the adrenal glands. Now, adrenal glands are all about cortisol, right? Cortisol, steroids, something your body produces, by itself. Now, there's too much and too little. So, which is adrenal glands. So too much cortisol is called Cushing's syndromes. It is usually caused by giving too much steroids to a child for too long of a time, and they get this Cushing syndrome. What do you see with this? And this is important. You think the kid is big and fat and puffy and gains weight, but you've got these very emaciated extremities usually. The thin arms, the thin legs, but it's the big round face, the humpback, the big abdomen going on, but your extremities are going to be really emaciated looking. So how do we treat Cushing syndrome? Well, taper off the steroids and you'll go back to normal, which is great. So what do you see also besides these skinny little arms that I'm talking about? All of a sudden kids are getting chin hair on their little chins, those big round face, the weight gain for sure. But anything with steroids, you're going to see that poor wound healing that goes on, and you're going to see bruising going on. And of course, those fatty areas, like I said. Congenital adrenal hypoplasia. Hypoplasia. Now, what is that? Well, congenital adrenal hypoplasia is when its sex hormones are being touched. And the child is born with ambiguous genitalia. Now, if you see this picture down there, That is a vagina, which looks like testicles, and it's just a prominent clitoris, but it's neither nor. And if you go in and look, these children will never be able to have children. But we will be giving that aldosterone and cortisol treatment for life for these children. So we have to assign a sex. Are you a girl? Are you a boy? It's going to be a decision made by what the parents want, by hormone testing, ultrasounds, etc. But they'll never, ever be able to have children. So we give the cortisol back to these children, and it will be for life. Neurological. You know, you talk about dysfunction and, you know, the head and the brain, and what do we need to do? Well, there's many different things that can affect the head on a child, whether it's infection, whether it's swelling, or other stuff. It could be, you know, even your meningitis. So let's talk about seizures. Well, one of the things about seizures is literally somewhere in the brain, all of a sudden a piece goes bzzz, and it goes haywire. So which means it's touching things that your body does, and it doesn't know what to do. So it goes into the shaking. It'll go into the foaming at the mouth, tonic and clonic, you know, which is what can go on with these children. Now, sometimes children get fevers, get fevers and causes a seizure. That does not mean they're going to have epilepsy. One seizure does not denote that this child is going to have epilepsy. But the thing about seizures is we need to, number one, make sure that we protect them and turn them on their side and remove all the sharp objects out of the bed. And, you know, call a response team, because you don't know how long it's going to go on for. And monitor, when did it start, what it looked like, so you can document it. And as I said, fever is one of those things you might see, but all of these other stuff can also cause seizures in children. Of course, infections, anything where you cause head injury, whether it's a lesion or a hemorrhage. Metabolic issues in children, many times we don't even know they have it until after they have seizures. And of course, malformations, genetics, and of course, if they take something in that they shouldn't have taken. So seizures are something that most of the time in the end, we don't know why it happened. I mean, if it's a tumor, we know it's a tumor, but a lot of times we don't know. So again, the first priority for a nurse in a seizure is protecting them, giving them the safe environment. Clear all the area for sharp and harmful objects, place the bed flat, remove the pillow, roll them on their side to prevent aspiration. You know, get the rescue team in there, or whatever it's called in your facility, you know, and just document what has gone on there. And not only you do that, teach a parent what to do. Now, there's all sorts of seizures. You know, it could be just a simple little eye flinching or blank stares. I think the most common that you think of when you think of seizures is the tonic-clonic. This is when the flexion, extension in the arms are going in and out. They do have a loss of consciousness. They're going to be jerking. They'll be foaming at the mouth. That's usually the ones that we think about. So that's the one that when we talk about seizures. Cerebral palsy. It's something that happens, whether it's intrauteral or it's something that happened, a hypoxic episode at birth. Many different things can cause cerebral palsy. Has to do when the baby is developing intrautero. There are different types of cerebral palsy. You know, there's dyskinetic, which is non-spastic. These children are able to move more. Ataxic, mixed. The spastic is the one that mostly that I've dealt with. You know, my little guy from Patches, this great facility that I used to do clinicals at, Jonathan is a very spastic CP kid. He was 7 or 8 years old in a wheelchair. That kid was alert. He would see me, the smile would go ear to ear, and he would start just getting so spastic because he knew I was going to come give him a big hug and a big kiss. So spastic is poor control. They can't maintain their balance. and that hypertonicity. Can you imagine your arms always flexing? He actually got Botox to try to help him relax. Head injuries. Kids fall off of everything. You know, I've talked about my toddlers, the dive bomb kids, off of the couch, onto the coffee table, missed it onto the floor, and bop, there goes their head, right? So the causes for him, motor vehicles will always be a number one in all the sort of injuries, but falls is the other thing too. So something about the falls is when we have a child who's had a head injury and this child is a little bit confused, these are things that we need to monitor, you know, this child, and looking at if it's getting worse. And worse, I mean, probably bleeding more into the brain. So always look at their level of consciousness, okay? Many children, head injuries. I've seen one kid fall off a second-story balcony off of an apartment building, came in, and this child was actually fairly alert. And then all of a sudden, the kid was like 3 or 4. So it's hard to, you know, his level of consciousness. But all of a sudden, he kept saying, "Where's my mommy?" And mommy'd be, "I'm right here. Where's my mommy?" So we knew something was going on. So a change of level in consciousness, and they're getting a little bit more confused. Also, children, unlike adults, vomit, okay? Adults with head injuries usually don't vomit. Children do. They don't like their head bumped to that force. So if you start seeing vomiting increasing, you start seeing a headache that gets worse and worser, if there's a word like that. And then you see those pupils changing. We know something's going on. So vomiting, changes in level of consciousness, headache that gets worse, that can even wake them from the sleep, there's increased pressure going on into the brain, and we need to take care of it. So this is, again, caring for a child with a head injury. It's important to monitor that change in the level of consciousness, getting more restless, or now you can't wake them up, vomiting more than 3 times, the pupils are changing, their vision, they can't see right, or they get up and try to walk, they fall over, or complaining of a headache is a problem. And the worst of all the observations that you can have is a fixed dilated pupil that is a neurological emergency. Well, what does that mean? Well, that big black thing in your eye is big and it does not respond to light. What is that telling you? The pressure in the brain has gotten so big that the pupil cannot respond. That child needs to have some sort of evacuation of that blood or fluid, whatever in that brain quickly, or the brain will die. So it's an emergency. Spinal cord injuries. You know, I have a little girl that, a little boy who was 16, came in playing baseball, slid into third base, and you could hear his neck crack when his head hit the defender's knee. He came in and he had an angulated, and it was literally, your cervical spine should be straight. His was angled. It was quite pronounced. And my priority, and I was the trauma, you know, primary nurse. So that was my patient and I was not going to hurt him. My priority was to keep that spine immobilized and to talk to him and let him know what was going on so that he kept that spine immobilized. That child had some neural deficits in his lower extremities and couldn't move the right side foot, and the left side was getting weak. So he could have really been paralyzed. But 2 weeks later, I visited him in a room and he was moving everything. He was going, you know, for therapy as an inpatient afterwards, but he was going to be fine. He was going to gain his strength and walk again because a nurse watched his spine. That was my priority. And I even did an MRI through the emergency room, which is unbelievable. So I'll never forget that little guy. Meningitis. It's an infection on the meninges in the brain. What are you going to prepare for? What do you know is going to happen for that child? Spinal tap, right? I want to know what that bacteria in that brain is. Is it viral or is it bacterial? And if it's bacterial, my number one priority, antibiotics as soon as I possibly can. So if we have bacterial meningitis, the sooner that we can get antibiotics in this child is the best. So prepare the child. Have them know what's going to be going on with the spinal tap. They'll be on their side. They'll feel pressure. They shouldn't feel pain. And let me tell you, if you see that cerebrospinal fluid and it is now white and milky, you know it's bacterial. Then you get the results back, low glucose, increased protein, you know that this child is bacterial. Bacteria loves glucose, so it eats it up. So the glucose is low and it leaves the protein alone. And of course, white blood cells. Following any spinal, whether it be anesthesia, whether it be a spinal tap, you need to keep them flat or they'll get headaches. Now, you get a kid with meningitis, or you get a kid who's getting all of this inflammation on the brain and swelling called cerebral edema. Now, you start to see some signs and symptoms of increasing intracranial pressure. How do you get rid of that extra fluid in the brain? We need a diuretic, right? And it is not, and I'll say it again, is not furosemide. It is mannitol. Mannitol, specific for the brain, okay? Mannitol for the brain. Furosemide doesn't work well in the brain. It's more peripheral or for your lungs. Mannitol is for your head. So if we're giving a diuretic, what are we going to do? Well, of course, monitor intake and output. Let's see how much fluid is now coming out and monitoring your blood pressures and heart rate, because we might actually get too much out or we may not get enough out. So very important, intake and output. So again, monitoring the level of consciousness, lethargy, headache, projectile vomiting is a key. Now, in infants, thank goodness, those little fontanelles they have, you'll see it tented. It'll be up and around and it will be tented at rest, not crying, just sitting there. And then we know they have some hydrocephalus or something going on in their brain. Now, a myelomeningocele is when the spinal column does not close completely. So your meninges and your spinal column are born on the outside of your back. So those nerves have been stretched. And those nerves supply the bladder, the bowel, and the lower extremities. Many of these children have sensation lost in the lower extremities. Many of them do not have urinary function. So they need to be catheterized every 4 hours. So one of the goals of a myelomeningocele is trying to keep their bladder working the way it should, getting their best. And of course, monitoring their bowels, making sure that they are stooling, because they don't have nerves. They don't feel it. They don't know to push. Hydrocephalus, one of the things that we can do is put in a VP shunt. Now, hydrocephalus is a lot of fluid on the brain. It's usually because the fluid's not draining the way it should. It gets stuck in the head. And usually you will see kids with these headaches. Usually they're young children. You see fontanelles big. And what we do is we put in a ventricular peritoneal shunt. That shunt goes from the fourth ventricle and it goes into the peritoneum and just drips down fluid to prevent too much pressure in the brain. You do not touch this shunt. You do not pump it. You leave it alone. All you need to do is measure head circumference and abdominal circumference, and that's it. And then monitor the child's status. That's all we need to do. Duchenne muscular dystrophy. This is the muscular dystrophy, neuromuscular dysfunction that your Hesse loves, your NCLEX loves. And when we talk about muscular dystrophy, we talk about muscles and nerves that don't work the way they should. Or it's a progressive degeneration of muscles, which is what Duchenne's is. Now, Duchenne muscular dystrophy is inherited from mom. It's an X chromosome that causes it. So if they have one child with Duchenne, the possibility, and usually they're boys, they could have another child with Duchenne. Usually we don't find these till the kid's about 3 years old. So they're up, they've been walking, but you know, when they walk, they're waddling, right? But that's what Duchenne does. It's a progressive degeneration of nerves and muscles. So they start falling, they start waddling, they start like the Gower sign. They crawl up their legs to stand up. I mean, that's what I do all the time as an old lady. Let's crawl up my legs because it's easier. But that's what these kids do also. And also they have that big inward curvature of the lumbar spine. So it ends up they have really bad muscle degeneration. Our goal is to try to keep those muscles moving. Now, diagnosing this sometimes can be difficult. You know, we don't know, excuse me, we don't know exactly what it is. So what we do is something that measures the nerves and how the nerves are connecting from this side, this area to this area. And we do that through that little machine you see in the upper side called an electromyography or an EMG. Now, I had one many years ago. I had a bad neck and they were checking my nerves in my neck. Let me tell you, when they put that nerve, they put an electrical shock and it shoots and it goes from the arm up into the head. And there is discomfort afterwards. Please warn your parents. And if the child's older and can understand, if it's it hurts a little bit, they can give some Tylenol or Motrin for it, whatever can help, okay? So waddling, frequent falls, Gower sign, lordosis, progressive degeneration of their nerves, and it's usually respiratory and cardiac that in the end, they will kill them. Okay, submersion, drowning. You know, I live in South Florida, so I've seen a few of these in my career. What happens in drowning is their lungs get full of water. So the biggest concern is monitoring their lungs. They had a hypoxic episode. So that hypoxemia is what causes problems. And it can happen up to almost 3 days later where their lungs start to fail on them. These children, many of them come to the emergency room. They're already running around and they look great, but we need to keep them and watch them. GI problems. Well, GI problems, remember, mouth to anus, that's where you eat your food, you get your nutrition, and it collects everything, you know, and so the body can use it. So one of the biggest issues with children, and they can become dehydrated so quick, is dehydration. Children their bodies don't like to be dehydrated. So if you have a child who's vomiting and cannot take any oral type of therapy, they need to get an IV. But remember, one of the things that can show you how dehydrated they are is electrolytes. So get a set of electrolytes and then start the IV and give fluids. Now, if they're just diarrhea and they're not vomiting, you can give oral. But remember, all depends on patient condition. Awake and alert, just diarrhea, give them by mouth. If they're vomiting and they don't take anything by mouth, of course, you need an IV. Checking the electrolytes will tell you your status and how you are starting out. Vomiting, well, there's all sorts of vomiting that we have here, right? Now, when a child, again, is vomiting, you can't give oral, you're going to give IV. And we're going to be checking their electrolytes for sure. If they can have PO, there's all different things. Now, Pedialyte is usually your younger infants. And then they get to Gatorade, Powerade as they get older. There's more sugar in it. So that's why they don't usually use that for infants, unless that's all you have. And you can half and half it if you need to at home. But nursing care management of vomiting, if they're vomiting and they look like they're dehydrated, now, what do they look like with dehydration? Well, their eyes will be sunken, no tears. Their mucosa is going to look dry. They're going to look pale, almost yellow. Sunken fontanelles if they're that young. Poor capillary refill, decreased urinary output, and then the obvious elevated heart rate, decreased blood pressure. Those things you do see, but the no crying with the tears, that is the kid's crying. You're like, yeah, but you're not having tears. Like, oh, this kid's pretty bad. So vomiting has signs of dehydration. Do the metabolic profile. Now, when you're giving a bolus of fluid, only bolus normal saline. Never, ever bolus with dextrose solutions, and never start potassium until you have a potassium level from the lab or until they urinate, because with dehydration, giving potassium could kill the kidneys. That's why we watch the potassium before we add it to the fluids. We know they may need it, but we have to be very careful. And if they're vomiting, tell the parents, please don't give them anything by mouth. Let's rest that tummy a little bit. And of course, we'll give some antiemetics. Now, there's different sort of vomiting in children. There's the vomiting from gastro. They ate something bad. They caught the GI bug. All right, that's just vomiting and vomiting. Now, there's also something in the very young children. The youngest I've seen was 3 or 4 weeks, and it's up to about 3 months. But that 6, 7 weeks I have found is that time where it's the golden time where I usually will see it. So pyloric stenosis. The thing about pyloric stenosis and vomiting is it shoots out projectile, as in it could hit something 10 feet across the room. I'm telling you, it is more forceful than you can imagine. I've seen children, they turn them around and the garbage can is like 4 feet away and they hit the garbage can holding the kid that far away. I mean, it is projectile. Now, if I get a kid into the emergency room complaining of vomiting, I'll say, is it a dribble, which is gastroesophageal reflux, which babies do have, or is it projectile across the room? Now, if they tell me it's projectile, I'll take my hand and feel in their mid-abdomen underneath their xiphoid process, and I will feel that little olive-shaped thing. It's like a little marble. And you're like, yep, this is a pyloric stenosis. Now, what is my job then? When I've determined, even before the physicians say, I'm going to make that child NPO. And because infants this young should never be held NPO, I'm going to start IV fluids to replace the oral. Furthermore, they've been vomiting all their food. It hasn't been able to go down, so they're dehydrated. And you want a baby to be hydrated going to surgery. And all they do is a pylotomy, and they open that up. And they usually have no problems for the rest of their life. But can you imagine having a 7-week-old infant going to surgery? It's very scary. So being a nurse and helping those parents is really important. Okay, diarrhea. Well, vomiting, let's go back to vomiting. Vomiting, you're vomiting all your acid out of your stomach. So you're being concerned about metabolic alkalosis, right? Now, when you are having diarrhea, that fluid that comes out is more alkaline because of those digestion enzymes that are in there. So you'd be in metabolic acidosis. On your HESI, there's 4 different questions on fluid balance and your blood gases. So I keep emphasizing that so that you will be understanding of that. So vomiting, you're getting rid of acid, metabolic acid alkalosis, right? Because your acid is gone. Diarrhea is coming out, alkaline's gone, so you're in metabolic acidosis. As I said, with diarrhea, most of the time we'll just orally rehydrate them. Now, if they also don't feel like eating because they don't feel good, which could happen, then we could give them the IV if they need to. Again, you're always going to check electrolytes for that. And the most important thing about diarrhea is to enter some food into these children, because if it's only liquids, how is that stool going to solid up and form? You need something. Appendicitis. Well, appendicitis, adult children, just about the same. When you have an appendix that they come in, you have a child come into the emergency room and they're complaining of abdominal pain, fever, it's been lasting since the night before. My first question is, describe the pain and where is it? Right lower quadrant, we have a problem and we know it's going to be a surgical problem. Now, if that pain stops before surgery, we know that appendix has burst, it's ruptured. So a ruptured appendix calls for an appendectomy, whether it's ruptured or not, but this is one that really needs to have surgery quick, and we need to go in there and remove as much of the debris as we can. Now, if you can imagine, this appendix has bust, all of this toxic waste has entered the peritoneum. It makes everything in there angry. The intestines are angry. So post-operatively, these children need to keep their bowels empty. We don't want anything there upsetting them. So we're going to put down an NG tube. And so we're going to get those gastric secretions out. We don't want the fluid going there and upsetting the intestines. We want it to heal. They are NPO, of course. And then because it's an infection that was in there, IV antibiotics. These children will be in pain. It is uncomfortable. You know, their whole bowel is irritated. So they'll be given pain medicines. Another thing is because we had an infected area and we closed a wound, sometimes that wound will dehisce because we don't know how good that tissue that we put together was. So we need to look at that wound. These children, all of the post-op stuff you do for an adult, coughing, deep breathing, out of bed, yes, yes, and yes, they must do all of those things. So make sure they're medicated before they do it so that they can get up, get out of bed, and they can cough and deep breathe and prevent any sort of complications. And your priority is IV antibiotics on that child. Meckel's diverticulum is like a little outpatching with a little tab in the lower small bowel, and it has a big blood vessel in it, and it rips. And all of a sudden bleeding comes through the intestines. And you will see maybe slight tenderness in the abdomen, but nothing really great, but you'll see what we call painless rectal bleeding, and that needs and requires surgery to fix it. Hirschsprung's disease. Well, Hirschsprung's disease is an area in the descending colon that has absolutely no nerves. It's, excuse me, an aganglionic portion is what they call it. The ganglions are the nerves. So there's no nerves, which means there's no peristalsis, which means there's no nerves, no pain. And everything in the body sits there and collects, and it gets bigger and bigger and bigger. So, and you're like, well, didn't the child act funny? Well, they don't feel it. There's no nerves there. What we would see in this, usually it's an infant we find it in. It'll be that infant that does not stool at birth within the first day, day and a half. Or they have this, if you look at that little brown, little no ganglion cell things there, that little thing that sticks down, maybe a little bit of squirting of ribbon-like stools might come out there. But that's about it if you're lucky. But usually it's none or tiny little ribbon stools. What we do a biopsy and an x-ray, find out no nerves, send them to the OR, and they will get a colostomy. It will be closed later on, but they need the bowel to rest for a while. So Hirschsprung's, ribbon-like stools need a colostomy, which will be closed later on. Hepatitis. Well, hepatitis, the big thing is just make sure you wash your hands. And, you know, treating these children is just, you know, we just have to protect ourselves, but we're in precautions for everybody, right? Standard precautions. Wear your gloves when you're in any contaminated thing. Another thing with hepatitis, a good high protein, high carbohydrate diet is good. Now, you should on hepatitis decrease the fat, but milk is a good choice for this child, which is like, huh, really? So you don't want those high fat things, but milk is a good choice and some high protein is good. Meat, fish, fruits, vegetables, and milk are all good. Celiac disease, this is all about the type of flour that these children can't have. Wheat, barley, oats, rye. Yep, can't have any of them. But there's rice flour now. They can have rice, okay? But these children can have dairy and meats and fruits and vegetables and omelets and, you know, a bacon omelet with a banana and a glass of orange juice and a glass of milk. I mean, come on, that's a great meal. But if they're going to have any bread or breading, it should be that rice flour. And they've got some really good stuff out now. And we know celiac is all about gluten because it irritates the small bowel and creates a lot of pain if they don't keep away from gluten foods. Now, I mentioned gastrointestinal reflux or GERD. And this is the reflux. It goes up and down from the belly, tummy, up the esophagus, and it burns and it hurts. In infants, you'd see a little spit up. When we have pyloric stenosis, it's projectile, right? Now, in older children, they can have reflux, they can have GERD. And what you see is a kid who's constantly coughing. Well, why are they coughing? Well, they are coughing because the food's coming up and they're having mini aspirations into their lungs. And that abdominal pain and heartburn is because of that food coming from the stomach up their esophagus and it hurts. So we can treat them with medicines, your Zantac, your Pepcid, any of those medicines that adults take, children take, but they're going to have in children doses, milligrams per kilogram, micrograms per kilogram, not just a whole pill like adults. The other thing they can do is something called a Nissen fundoplication. And all they do is they take the upper part of the stomach and flip it over so food can't go up the esophagus. This is something they use when they put gastrostomy tubes in adults and children, and it prevents food from going up the esophagus and it prevents aspiration. So it's called a Nissen fundoplication. Now, esophageal, tracheoesophageal fistula or esophageal atresia are lack of connections or extra connections between the trachea and the esophagus. And they're both treated the same. So esophageal atresia, no food can go down because the food's not connected to the stomach. So this kid can't eat. It just will come back up and they'll aspirate. So if you try to feed them, it's going to go right in their lungs. So we do not feed these children. So our job, the tracheoesophageal, if you fed them, it will go right down the esophagus, right across that fistula, right into the lungs. So we're not going to feed these children. Keep the head of the bed elevated, have suction at the bedside. Remember, make sure they get a nice little pacifier to suck because this kid's not going to be able to eat. And we need to promote good growth and development. That pacifier is a big deal, that they need to suck on those things. Now, preoperatively, how do we treat these children? They can't eat. So IV fluids, but we're going to give antibiotics. Why? They're having little aspirations. So we don't want this aspiration into the lungs causing pneumonia and causing an infection. So IV fluids and antibiotics. Okay, gastroenteritis and dehydration. Again, we've talked about this a couple different times here. So we know that dehydration, when they're severe, they need to be put on IV fluids. We never hydrate with dextrose as in a bolus. We do saline, and then we'll add an IV with dextrose later on, but not now. Again, no potassium until they voided, and you need a metabolic profile on these children. Now, nephrotic syndrome. Well, nephrotic syndrome has nothing to do with renal failure. Nephrotic syndrome is not renal failure at all. you're urinating well, but the kidneys say, hey, protein, I don't like you, and they keep getting rid of you. So protein is gone from everywhere. What does that mean? Well, you're going to see massive proteinuria. So your urine is 4+ protein. The blood, the protein or the albumin, which we know we need for giving drug doses, if we don't have good protein in the blood, we're going to need smaller doses of medications because it'll all be free flowing in the body. So hypoalbuminemia, it causes problems with lipids, but because there's no albumin, this fluid is pulled into the interstitial space. From interstitial to extracellular, the whole body swells up. The tongue, the mouth, the eyes, everywhere. I mean, that's why they start to lose their appetite, because of the swelling in the mouth, that it hurts. So this is a child who is urinating, okay? Proteinuria, they have it, yes, but they are also, one of the things we have to be very careful with is daily weights, okay? They tend to, because the fluid goes in the body and it goes in extracellular into the tissues, it's just getting swollen and swollen. They're gaining weight. So daily weights are important. Salt restriction, fluid restrictions on these children, because we want to get rid of that fluid. And we treat these children with just steroids, and it does help. It is a lifelong, it's not something that we can say it was due to something and cure it. Again, a lifelong thing. Now, acute glomerular nephritis. This is when the kidneys get all inflamed and you stop urinating. You gain, there's fluid somewhere, right? So you start getting edematous. You have extra fluids in the body, it's going to go into the lungs, high blood pressure. Then you're going to start seeing hematuria, proteinuria, and this child's going to look sick, okay? These children usually have had some sort of infection, usually streptococcal. Again, acute rheumatic fever or acute glomerulonephritis is due to a streptococcal infection. So again, we're gaining fluids again. We're holding on fluids. So number one, it was due to a streptococcal infection. So we're going to treat it now. We're going to give antibiotics. But what is our nursing care? What do we need to be paying good attention to? Well, we need to look at that fluid balance, daily weights, intake, output, and we're going to be measuring those abdominal girth measurements. These children are going to be very susceptible to infections, so good hand washing, and of course, low sodium, and they'll be on just a limited amount of fluids. Again, I made a nice picture for you. I found one. I thought that was good. You can look at it. Now, I finally found a really good picture about hypo and epispadias to give you all an understanding of exactly what they have to do in order to fix this thing. Now, hypospadias is when the opening of a penis, the urethra, it's not on the tip, it's underneath. Anywhere underneath it could be. And epispadias is on top, but it's not on the end where it should be. So the first thing is these children cannot get circumcised. They need that foreskin for closure. This might be a deal in the Jewish faith, right? Because there's the bris and it's part of their religion. They cannot do it. They need to keep that foreskin. So that could be a problem. Now, they usually try to get this done before they're potty trained. So between 6 to 12 months, they do it. They use the foreskin to help close it up. And what they do is they put that stent catheter, something in there, in the end of it, to hold that lumen of the urethra open, okay? Usually it's in there up to 2 weeks. How do we take care of that? We just make sure the tube is in the diaper so it doesn't leak everywhere. We don't do anything to it, nothing, leave it alone. Okay, we don't want to dislodge it. So we just change the diaper frequently. If there's a dressing on it, they want a dressing, you do a dressing, but we leave that little stint alone. And the kids actually do very well with that. Chronic kidney disease. Chronic kidney disease is, when the kidneys get worse and worse and worse, and, their function becomes less and less. Now, one of the things about chronic kidney disease is, the treatment and things that as children, what are we going to watch out for? Well, we know that their red blood cells aren't going to be producing the way they should. So using erythropoietin helps increase the production of red blood cells, which will decrease the amount of blood transfusions. Also, they can lose vitamin D and calcium due to this chronic kidney disease. And that can cause something called osteodystrophy. Well, osteo is bone, dystrophy means it's just not right, not forming correct. It will cause these children not to grow the way they should. And it will cause bone pain and bone malformation. So replacing vitamin D and calcium on chronic kidney disease in children is very important. And of course, the erythropoietin. Dialysis. Well, in children, many of the itsy bitsies, the younger children, get peritoneal dialysis. It is actually a great choice. It's done at night. Parents can do it. I had one child of little Willie, probably some of the best dressings I've ever seen by a nurse or parent, or even myself, because I have sort of OCD, little neat, little cute little dressings. Everything had to be just so. But these peritoneal dialysis catheters are that opening into the peritoneum, and they put fluid inside. It sits there and it gets drained. And each time fluid goes in, sits and drains, it's called a cycle. And they do it at night on a machine. They program it in sterile condition, they'll hook up their little machine, and it will 8 or 10 cycles a night, depending on the physician. Now, one of the things that's the key thing for these parents to watch is if they see a change in the color of the fluid coming out, or extra, it doesn't look the way it normally does, or shreds of stuff or anything, they need to call the physician immediately, because this is the kidney. This is the only kidney they have. They cannot go on hemodialysis. That fluid, the flow of blood can rupture vessels in their brains. So small children have to have peritoneal dialysis. So we need to teach them. They see a red abdomen, tenderness, or a change in the color of that diastolate from clear to cloudy, immediately call a physician. What will the physician do? Anticipate. You'll get antibiotics, but remember, you got to call the physician to get antibiotics. A renal biopsy sometimes is done when you're in chronic, polynephritis, pylos all the time, or constant urinary tract infections, and they'll do a biopsy. Now, this is a very similar post-op care, almost like cardiac catheterizations. Their NPO before, depending on their age, depends on when, they'll be getting something to make them drowsy, because they do put a needle through the back into the kidney under ultrasound. If you see that little probe, they have ultrasound, they'll put a needle in and they'll aspirate a little bit of urine. But they've punctured through the skin into the kidney. The chance of leaking out onto the dressing or leaking into the abdomen can happen. So post-op, what are we going to do? Well, we're going to have a pressure bandage on there, a sandbag if they're old enough for sure. They must stay in bed for 24 hours. And of course, because of this urine, we've touched the kidney, we're going to monitor intake output, and we're going to monitor for any leaking. We're going to monitor that dressing, and we're going to monitor for any pain or tenderness or swelling in the abdomen. Kidney transplants, transplants, do need to be done. I mean, my little Willie did get one. The biggest thing with transplant is the most common is rejection. Rejection is what happens, and it's the most common of any failure of a transplant. They will be on immunosuppressant therapy for life. And the signs of rejection are, the urine doesn't work so well. I mean, it's the risk for infection related to immunocompromised state and post-transplant medications. That's a great nursing thing for this child. But fever, swelling, diminished urinary output, those are all things. And fractures. Fractures are so common. Now, the one thing that you need to know about fractures is you have simple ones that bones don't come out, and then you have what we call the open or compound one. Well, we know that there is these children. We need to find out what happened. We need to do x-rays, give them something for pain if they need it. If it is an open or a compound, it's the same word, they need to be placed on antibiotics. The risk for infection is great and the bone sticking out. So it could cause osteomyelitis. So these children will be on IV antibiotics for an extended time. Could be 4 or 6 weeks, depending, because osteomyelitis is very difficult to treat. There's all different sorts of crack, this, that. Is putting them in a cast and making sure that we do watch them, look for the pain and the pressure and the sensation and the movement, that all of these things are good. So remember those 5 Ps when you think about fractures, that we do check those once they have a cast on. I mean, usually it's, the forearms in children, because what do kids do? They fall down and put the arms out and they fracture. I've seen both of them get fractured. So osteomyelitis, we're sort of mentioning that when we're talking about this fractured open or compound fracture. Now, osteomyelitis is redness, swelling, and of course you'll see, your WBCs go up. It's a very painful actually thing. Could be on a little finger, could be on a little toe. As I said, these children need to be, rest is a big thing. If it's on the foot, they don't need to be up and walking around. They need to keep immobilized. Pain management, of course, depending what they need. And then it's parenteral antibiotics. It's not by mouth. They're going to need a PICC line or something put in, and giving those antibiotics from up to 6 weeks or even more. And sometimes they'll do even more by giving oral for that. Now, these are bones that are healing. So these children do need good nutrition, good protein, because they need that bone healing. Sometimes, if we don't treat them right, you can end up with an amputation, a finger, a toe, a foot, a leg. That can happen. I've never seen it happen, and thank goodness, but it can. So cast care I was talking about, right? Cast care, how do we take care of it? Well, I've seen children get a cast, leave the hospital, go home, put their bathing suit on and jump in the pool. They go, oops, maybe I shouldn't have done that. Well, you can't have a wet cast. It needs to be changed. So one kid do it 2 times. The mother said, if you do it again, I'm not coming back. But it does happen in some of these children. So keeping it elevated, keeping it cool, moving the fingers, when we get home, those things are really important. These children, we know they heal quickly. It could be a kid the age in this picture, 4 weeks is all he needs on it. So again, here's your 5 Ps, very important thing. Pain, pulse, pallor, paresthesia, paralysis. Because I can't move it, it's feeling numb, it's looking white, I don't have a pulse, and it really hurts and it really swells. These are things that must be checked. Now, another thing we can do with fractures is what we call traction. And this is a great picture here. It's basically, this is called a skin traction. It's Buck's traction. And I've actually seen this in the emergency room. Little boy came in about age 8, and he complaining of swelling in his right upper leg, and he had a fractured femur, and he was in a lot of pain because those bones were sticking and it was hitting the nerves in the leg. So you take that device, hook it up, and you pull it with a weight. And what happens is the muscle spasms, which are horrible, relax. And then those bones sort of come together and it stops the pain. I mean, most of the pain will go away. It'll immobilize it to the point where if they're going to do surgery, they can wait. They don't have to do an emergency thing. One thing about these sort of traction, there are weights that go over that hang. Nursing care of weights on traction. Number one, never, ever, ever, ever remove it. Make sure that they're free flowing because that's pulling that leg out, preventing pain there, okay? And to document on the nurse's notes what weight was there and that you did check it. Always, you're going to be checking that circulation there, okay? So keep those routes uninstructed. You don't take them all for bed baths. None of that stuff. Should be on 24 hours a day. It's not like scoliosis and like putting them in, their brace. On the brace, you can take them off for 1 hour a day to take a bath. 23 hours a day that they should be on. Now, one of the things about scoliosis, these are your adolescent children. We know adolescent children are all about body image. So now they're wearing this hard thing underneath their clothes and they're just not feeling well about themselves. Plus now they're crooked because one of their shoulders is higher than the other because of the S-shaped curvature in there. Now, trying to maybe give cute looking braces can help a little bit, but these children do need a lot of support from the nurses about it. Now, usually bracing is up to about 45 degrees, 40 to 45 is where they brace it. After 45, at 50%, they will be doing surgery where they take rods and they try to straighten out the back. But if they can, these children will be in a brace 23 hours a day and they'll be doing exercises to strengthen their muscles. So scoliosis is that S-type curvature. Under 45%, we're going to wear a brace and we're going to do exercises. So again, be careful with these children. With their body image, it's a big thing. They're concerned about it. You can see how big and clumpy it could be, but you can see you can make it sort of fun looking. Lupus, autoimmune disease. We know lupus is the butterfly rash. It's when the body attacks the organs and they are severely immunodepressed. One of the things with lupus that it's not said a lot is that these children, you must avoid sunlight. Very important that they be out in the sun. We have sunscreen on and it should be minimized or go out later on. These children should have a medical alert tag to let people know, and they'll be on steroids and antibiotics prophylactically before procedures. Juvenile idiopathic arthritis, JIA. Used to be JRA, but they changed it to JIA. Basically, what is this? It's when the body starts attacking joints. But what do you see? Well, these children, just like me, stiff in the morning, gotta really stretch before you get up and out of bed and get those bodies moving. Children, because of this joint problem, do have some growth disturbances. You're going to see joint disfigurement in these children. And then there's something called uveitis. And it's these children should have yearly eye exams. It is an inflammatory eye disease, and it can cause vision loss if not checked. And that is with JIA. Uveitis is one of it. So joint disfigurement, growth disturbances, morning stiffness, and loss of motion are things that we do see. And then our last thing we're talking about is Guillain-Barré. Well, Guillain-Barré, usually there was an upper respiratory, about 3 weeks before, some sort of viral something. And all of a sudden they start falling, shuffling their gait. And they're like, I don't know what's going on here. And then it starts from the feet and it starts going up. And usually when it gets to the point where they become incontinent, they send them to the physician. They are already pains in the toes and the weakness and the waddling gait, etc. So it goes ascending feet and it goes all the way up. The problem is it attacks nerves. Number one nursing priority is monitor the respiratory status. When it hits the phrenic nerve, they do not breathe at all. These children or adults end up on ventilators for, could be a 1 week, 2 weeks, 3 months. We don't know. But then all of a sudden, you'll see them breathing over the ventilator, and then it goes down, descending, and it goes away. And then they need a lot of physical therapy during and after this. So how do we treat this? Well, we do give IVIG, intravenous immunoglobulins, and that does help with it, trying to boost the own body's immune system. So we're going to be monitoring their lungs, and we're going to be given IVIG. So remember, again, there's always 5 basic doses calculations. If you want my YouTube channel for this again, I'll be more than willing to send it to you all, and I'll send you 3 worksheets that go with it. It's also good for med-surg. So I believe in all of you. I think you all can do it, and thank you for joining me today.
I have a question, Professor.
Yes.
With the Guillain-Barré, they do not get a flu shot?
It is a viral thing, and there's controversy on that one. I remember that there was controversy about getting it or not. And I think the last thing they said is they do, but it's gone both ways. That wouldn't be a question you would see.
Right.
Oh, well, that's good. In our book, it said, in MedSurg book, it says where you have your flu shot information, it says if you were diagnosed with Guillain-Barré within the last 6 weeks, you don't get a flu shot.
Well, if it's at that time, but if they've had it later on, they can get it. But during that period of time, no. That's why they give the IVIG, just to boost the immune system.
Gotcha.
Are you going to put your PowerPoints? Where are you going to put those at?
What do you want? Every professor has received my PowerPoints.